if the pituitary tumor presses on the optic nerves.
That sounds like a profound change, really altering someone's appearance and how they, interact with the world. It shows how deeply our hormones shape us even after we're done growing taller.
It does.
And what strikes me is that irreversible part, once those bones thicken, you can't just undo it. A powerful reminder of the pituitary's command.
Absolutely.
So with such a wide range of symptoms, how do doctors figure this out? How is it diagnosed?
Diagnosis usually involves blood tests. They'll show elevated growth hormone levels. And then imaging, like X-rays or maybe an MRI scan, can show abnormal bone growth or reveal if there's a pituitary tumor causing the issue.
And what can be done? Is it manageable?
Yes, doctors have several tools. Medications are often used, specifically designed to inhibit or block that excess growth hormone. Surgery is also a key approach, especially a procedure called transphenodal resection, going through the nose, basically, to remove the pituitary tumor if that's the cause.
Yeah.
Radiation therapy is another option. And it's really important to remember, after surgery especially, lifelong hormone replacement might be necessary because the pituitary's normal function can be disrupted.
It really sounds like if these problems aren't caught and managed, the body pays a heavy price. What are the biggest long-term risks if acromegaly isn't treated?
Oh, they're serious. Untreated acromegaly can lead to chronic issues like high blood pressure, diabetes mellitus, and significant heart problems. These can definitely be life-threatening.
Okay, so that's too much growth hormone after puberty. Now, on the opposite end of that growth spectrum, you mentioned something about too little growth hormone.
Right, that takes us to dwarfism. This results from a deficiency of growth hormone, what we call hyposecretion. And this occurs during fetal development or childhood.
What causes that deficiency? Is it genetic?
It can be. It might stem from a congenital lack of GH, meaning someone's just born without enough. Or it could be caused by a brain injury, something affecting the pituitary gland during those critical early childhood years.
And how does that manifest? What does it look like?
Well, the main thing is short stature, obviously, typically falling well below the 3rd percentile on growth charts. Their growth rate is just much slower than expected for their age. Interestingly, while their head and limbs might look a bit disproportionate to their torso initially, the body generally develops proportionally over time. Sexual development can be delayed, though.
And intelligence.
Crucially, intelligence levels are almost always completely normal. That's a really important distinction. You might also see some physical signs like progressive bowed legs or an inward curve of the lower spine, which is called lordosis.
Okay, so how is dwarfism usually managed?
Management often involves growth hormone injections. These can make a big difference in improving final height and bone density. And, like with acromegaly, if a pituitary tumor is found to be the cause, either causing too much or too little hormone surgery to remove it, might be the way to go.
That's interesting. A tumor could cause either extreme?
Yes, it depends on which cells in the pituitary are affected and what hormone they produce or interfere with. That's why doctors are always watchful for signs like persistent headaches, vision problems that can't be explained, or even sudden changes in behavior. These could all point to a tumor needing attention.
Right. Okay, so we've seen how the pituitary orchestrates growth. Let's switch gears now to another incredibly vital function. Managing our body's entire fluid balance. This is where that hormone, ADH, antidiuretic hormone, or vasopressin you called it, comes in. And when it misfires, the body's water system can swing wildly, like from drought to flood.
You've set the stage perfectly. First, let's talk about the drought scenario. Diabetes insipidus, or DI. Don't confuse it with diabetes mellitus, the sugar kind. This is different.
Right, DI is about water, not sugar.
Exactly. It's a condition where there's a deficiency of ADH. This means your kidneys just can't hold on to water properly. They can't concentrate urine. There are two main types. Neurogenic DI is where the brain isn't making or releasing enough ADH, maybe due to head trauma, tumor, surgery, something like that. Then there's nephrogenic DI, where the kidneys themselves just aren't reacting to the ADH that is there. The signal isn't getting through to the kidney cells.
And the symptoms sound, well, intense. You mentioned huge amounts of urine. Like, how much?
You're talking maybe 5 to 20 liters a day.
Yeah.
Compare that to the normal 1 or 2 liters.
20 liters.
And it's incredibly dilute urine. Low specific gravity, low osmolality. Basically, it's almost like pure water coming out.
But here's the kicker, right? While the body is flushing out all this water, the blood itself gets super concentrated.
Precisely. The serum chemistry goes the opposite way.
Yeah.
You get hypernatremia, high sodium in the blood, hyperkalemia potentially, increased serum osmolality. The blood becomes thick, essentially.
And you'd see the dehydration, right?
Oh, absolutely. Polyuria, that frequent excessive urination, is obvious, but also polydipsia, extreme thirst. People often crave ice water specifically and in huge amounts.
Ice water, interesting.
Yeah. Then there's weight loss, profound muscle weakness, dry skin, poor skin turgor, where if you pinch the skin, it stays tented. Tachycardia, so a fast heart rate, hypotension, low blood pressure, and even decreased cognition, confusion.
So how do you manage that? You can't just keep drinking 20 liters of water a day.
No, you can't. Lifelong ADH replacement is usually key. Medications like desmopressin, which is a synthetic form of ADH, often taken as a nasal spray or a pill. And for someone living with DI, it's critical to constantly monitor their fluid intake and output, track their weight daily, and things like wearing medical alert jewelry are really important for safety.
Okay, that makes sense. Now, what about the flip side, the flood scenario you mentioned, when you have too much ADH instead of too little?
Right, that brings us to SIADH, syndrome of inappropriate antidiuretic hormone. Here, the problem is excessive ADH secretion. Common causes can be certain tumors, especially some lung cancers, head trauma again, certain medications, or sometimes it's linked to other unrelated diseases.
And this causes a really unique kind of fluid overload, doesn't it? You said without the usual swelling in arms and legs.
Exactly, that's a key feature. The excess fluid accumulates primarily in the vascular system, inside the blood vessels, not so much in the interstitial spaces between cells. So you don't typically see that pitting edema you might expect with fluid overload. The result is a significantly decreased urinary output. The kidneys are holding on to almost all the water.
So the urine becomes really concentrated, the opposite of DI, high specific gravity, high osmolality.
Correct.
And because all that extra fluid is staying in the blood vessels, the blood itself becomes diluted.
Yes, very dilute. This leads to hyponatremia, dangerously low sodium levels in the blood.
And that low sodium is what causes the neurological symptoms.
Precisely. When sodium levels drop too low too quickly, water moves into brain cells, causing them to swell. This leads to symptoms like mental confusion, irritability, lethargy, headaches, and in severe cases, seizures or even coma.
Wow. What other signs might you see?
General weakness, loss of appetite, anorexia, nausea, vomiting, and weight gain, but it's water weight from the volume overload. This also leads to cardiovascular signs like strong, bounding pulses, tachycardia again, and hypertension, high blood pressure, because there's just too much fluid volume in the system.
So how do you treat SIADH? You can't just give more ADH, obviously.
No, definitely not. The primary treatment is strict fluid restriction, sometimes down to just 500 or 1,000 milliliters total per day, which is incredibly difficult for the patient because they're often still thirsty.
Wow, that's tough.
It is. In severe cases, especially with neurological symptoms, they might get hypertonic saline, a very concentrated salt solution given intravenously, very carefully, to help pull water out of the swollen brain cells. Certain medications can also be used to inhibit ADH's effect on the kidneys, things like diclomycin or even lithium carbonate sometimes. Loop diuretics, like furosemide, might be used too, but carefully, because you don't want to lose too much sodium along with the water.
Okay, so if we put these two side by side, DI and SIADH, the contrast is really stark. It tells you so much about how ADH works.
It really does. Let's recap that contrast.
Okay, so diabetes insipidus, that's the drought. High urinary output, low ADH, blood is concentrated, hypernatremia, patient is dehydrated, losing too much fluid.
Right. And then SIADH, that's the flood. Low urinary output, high ADH, blood is dilute, hyponatremia, patient is overhydrated, but maybe without obvious swelling, retaining too much fluid.
And the fascinating thing is, despite being total opposites in fluid balance,
Both conditions often present with excessive thirst.
which must make diagnosis tricky sometimes, especially early on.
It definitely can. You really have to look at the whole clinical picture, the urine output, the serum and urine labs to figure out which way the ADH balance has tipped.
It's just incredible how those tiny pituitary hormones dictate such fundamental processes like growth and water balance. Okay, so from the master control of the pituitary, let's shift our focus down a bit to the adrenal glands, perched like little hats on top of the kidneys, right?
Exactly. And these glands are basically your body's primary responders to stress. They're also divided into two distinct parts, each with its own set of crucial functions.
Let's break that down. What's the outer part do?
The outer portion is the adrenal cortex. It secretes three main types of steroid hormones. An easy way to remember them is salt, sugar, and sex.
Okay, salt, sugar, sex. Let's unpack that. Salt.
Salt refers to the mineralocorticoids. The main one is aldosterone. Its job is critical for regulating electrolytes and fluid balance. It tells the kidneys to reabsorb more sodium, and water follows sodium, so that increases blood volume and blood pressure. It also promotes potassium excretion.
Got it. Sodium in, potassium out. What about sugar?
Sugar refers to the glucocorticoids. The most well-known is cortisol, often called the stress hormone. Cortisol does a lot. It helps regulate glucose metabolism, ensuring your brain has fuel. It affects fluid and electrolyte balance. And it has really important anti-inflammatory properties. That's why synthetic versions like prednisone are used so widely as anti-inflammatory drugs.
Right, okay. And the last one, sex.
Sex refers to the sex hormones, androgens and estrogens. The adrenal cortex secretes small amounts of these. In adults, the amounts are usually pretty insignificant compared to what the gonads produce, but they do play a role, especially in certain conditions or developmental stages.
Okay, so that's the cortex. Salt,
Mhm.
sugar, sex. What about the inner part, the medulla?
The adrenal medulla is the inner portion. This is your body's rapid response team for acute stress. It releases catecholamines, primarily epinephrine, adrenaline, and norepinephrine, noradrenaline. These are the hormones behind the classic alarm reaction or the fight or flight response.
Ah, this is when your body suddenly gears up for action.
Exactly. Think about what happens when you get a sudden fright or face intense stress. Your heart pounds, breathing gets faster, blood pressure shoots up.
Skin might get flushed or pale. Your
Yeah.
pupils dilate.
Right. Your body releases stored blood sugar, glucose, and fats for quick energy. Muscles might tremble. And things that aren't essential for immediate survival, like digestion, slow right down. It's all designed, evolutionarily speaking, to prepare you to either confront a threat or escape from it very quickly.
Makes sense. A powerful immediate response system.
Very powerful.
So now, what happens when these adrenal glands with their potent hormones go into overdrive? Or maybe the opposite, when they don't produce enough?
Good question. Let's tackle adrenal hyperfunction first. The main condition here is Cushing's syndrome. This is caused by the adrenal glands producing too much of those sugar hormones, the glucocorticoids, especially cortisol.
And what triggers that overproduction?
Well, it can be varied. Sometimes it's due to an overgrowth or tumor within the adrenal cortex itself. That's called adrenal hyperplasia or an adrenal adenoma. Other times, the problem actually starts back in the pituitary gland, a pituitary tumor that's making too much ACTH, which then overstimulates the adrenals. That specific type is often called Cushing's disease.
Ah, okay. Subtle difference.
Yeah. But interestingly, probably one of the most common causes we see today is the long-term high-dose use of prescribed steroid medications, like prednisone for autoimmune diseases or asthma.
So iatrogenic caused by medical treatment.
Exactly. Certain chemotherapy drugs or other autoimmune diseases can also sometimes lead to it. The manifestations, the signs and symptoms of Cushing's are often quite dramatic and visible. They create a really distinct appearance.
This is where we see those classic features, right? The moon face.
Yes, a very characteristic rounded, often reddish face, and the buffalo hump, that's a fatty deposit between the shoulder blades on the upper back and neck. You also often see central or upper body obesity, weight gain around the trunk, but often with surprisingly thin arms and legs,
Yeah.
almost like the fat is redistributed.
Yeah, and the skin changes.
The skin becomes very thin, fragile, bruises easily, and you get those characteristic purple stretch marks, or striae. They're different from normal stretch marks, wider, deeper purple or reddish, often on the abdomen, thighs, sometimes arms. Wound healing is also significantly delayed.
What else?
Hirsutism is common in women. That's increased facial and body hair in a sort of masculine pattern. Osteoporosis, weak bones, menstrual irregularities or absence of periods, amenorrhea, elevated triglycerides, high blood pressure, and because cortisol suppresses the immune system, increased susceptibility to infections.
Wow, that's a huge list. It really affects almost every system.
It truly does. It paints a complex picture.
When you describe all that, what's maybe one of the biggest day-to-day challenges for someone living with Cushing's beyond the visible stuff?
That's a great question. Beyond the appearance changes, which can be distressing, many patients struggle profoundly with chronic, debilitating fatigue and significant muscle weakness, especially in the legs and shoulders. And surprisingly, mental health changes are incredibly common and can be severe mood swings, irritability, anxiety, depression, sometimes even psychosis. These aren't just reactions to the illness, they're direct effects of the excess cortisol on the brain.
That's tough. And then there are the lab value changes too, right?
Yes, the fluid and electrolyte imbalances. You typically see hyperglycemia, high blood sugar, sometimes leading to steroid-induced diabetes, hypernatremia, high sodium, hypokalemia, low potassium, and hypocalcemia, low calcium, all driven by the excess cortisol.
Okay, so to help remember all that, you mentioned salt, sugar, sex for the cortex hormones. Is there a similar mnemonic for Cushing's?
Yes, a useful one is the 4 S's of Cushing's. Think salt, for the sodium and water retention. Skin, thin, fragile, purple striae. Steroid, representing the excess glucocorticoids, the sugar hormones, and sugar for the hyperglycemia.
Salt, skin, steroid, sugar. Okay, that helps pull it together. How is Cushing's managed?
Well, it really depends on the underlying cause. If it's an adrenal tumor, surgery to remove the adrenal gland, adrenalectomy, is often the treatment. If it's a pituitary tumor causing Cushing's disease, then pituitary surgery or radiation might be needed. If it's caused by long-term steroid medication use, the goal is to carefully taper down the steroid dose, if possible, under close medical supervision. You can't just stop steroids abruptly.
Right, that can be dangerous.
Very. Dietary changes are also important, limiting sodium to help with fluid retention, and limiting calories and carbohydrates to manage the weight gain and high blood sugar.
And after an adrenalectomy, if they remove the gland?
Ah, yes. If one or especially both adrenal glands are removed, the patient will need lifelong hormone replacement therapy. They'll need to take glucocorticoids and possibly mineralocorticoids for the rest of their lives because their body can no longer produce these essential hormones. Patient education on that is critical.
Makes sense. Now, just briefly, to really understand Cushing's, it helps to contrast it with its opposite, Addison's disease.
Absolutely.
Oh.
While Cushing's is about excess adrenal hormones, Addison's is a rare but serious condition caused by deficiency of these hormones, primarily cortisol and often aldosterone as well. It's adrenal insufficiency.
And what's the key sign that often makes you think of Addison's?
The most striking classic feature is often a bronze pigmentation of the skin. It looks like a deep tan, but it can appear even in areas not exposed to sun, like the palms of the hands, inside the mouth, on scars, or in skin creases.
Interesting. Why the tanning?
It's because when the pituitary tries to stimulate the failing adrenals by pumping out more ACTH, it also stimulates melanocytes, the pigment-producing cells in the skin.
Ah, okay. What other signs go with Addison's?
Besides the skin changes, common symptoms include progressive, profound fatigue, muscle weakness, weight loss, low blood pressure, especially postural hypotension, feeling dizzy when standing up, low blood sugar, hypoglycemia, salt craving, nausea, vomiting, and sometimes changes in body hair distribution. It's basically the body slowly running out of its vital stress hormones.
And is there a mnemonic for Addison's too?
Yes, a simple way to remember key features is focusing on the opposite S's from Cushing's. For Addison's, think sodium, low sodium hyponatremia due to lack of aldosterone, and skin, that characteristic hyperpigmented bronze skin. You could also add sugar, low blood sugar.
Sodium, skin, sugar, low. Okay. This can become an emergency, right?
Yes, absolutely. Without treatment, Addison's disease can lead to an adrenal crisis, also called an Addisonian crisis. This is a life-threatening emergency. It involves severe dehydration, sharp drop in blood pressure leading to vascular collapse, renal shutdown, critically low sodium, and high potassium levels. It truly highlights just how essential these adrenal hormones are for survival.
Wow. What an incredible journey from the pituitary's master control down to the adrenal stress response. It really underscores the interconnected nature of this whole endocrine system.
It really does.
Looking back at all this, what stands out most to you about how these tiny little glands can have such huge, widespread, sometimes dramatic effects on the entire body?
You know, the real aha moment for me, again and again, is seeing how seemingly unrelated symptoms, things like distinct skin changes or profound mood swings or these wild fluid imbalances from DI to SIDH or issues with growth, how they can all link back to the delicate balance of hormones managed by these central control centers. Understanding those connections, it just reveals the body's profound complexity.
Yeah.
A pea-sized gland dictating if you're constantly thirsty and dehydrated,